So very good afternoon, everyone. Ankura Hospital for Women and Children welcome you all for this webinar. The speaker of this webinar is Dr.Razia Adam Kadwa. She is a very renowned doctor as well as speaker in many national and international forums. So to take this session further, I would like to invite Dr. Srinivas Jappka. Sir.
Okay, good afternoon and welcome to all of you who have joined us today. A brief word about Dr. Razia Adam Kadwa. She completed her MD Pediatrics from the prestigious PGIMR Chandigarh, and then she has done her DM in Pediatric Neurology from the same institute. She is trained in the management of acute and chronic neurological conditions, CNS infections, and developmental disorders in children. And she's currently working as a consultant pediatric neurologist at Ankura Hospitals for Women and Children. She's a member of Association of Child Neurology, International Child Neurology Association, and Young Epilepsy Society of India. Over to Dr. Razia.
Good afternoon, everyone. Thank you, sir, for that good introduction. So today we'll be discussing briefly about treatment of generalized epilepsies in children. So pediatric epilepsy is a very vast topic. So it's not possible to discuss all types of epilepsy and epilepsy syndrome. So we thought we'll stick to one subsection of pediatric epilepsy today. So all of us who manage children, we know that children are different as compared to adults when it comes to all disorders, and epilepsy is not an exception. I'm not able to change my slide.
Okay, ma'am, can you just again you just close it? Again, you try sharing the.
Okay. Okay.
And again, if you, yeah.
That's fine. So when we compare pediatric epilepsy from adult patients, we know that we are dealing with a different kind of etiology. We come across neurometabolic disorders and cortical malformations and genetic epilepsies more in children as compared to those in adults. And seizures in childhood age group does not only have an impact on self-esteem and it's associated with behavioral issues, but it has a significant impact on cognition, learning ability, as well as the quality of life of the child. And it also has a significant impact on the family's well-being. So those aspects also need to be taken care of. And it's very important to choose the right drug for the right patient. We will see how to approach, analyze, and evaluate these patients. I will also touch briefly upon precision medicine. So let us start with a very common clinical scenario. We have an 8-year-old girl who is developmentally normal. She comes to the OPD with concerns of parents have noticed brief episodes of unresponsiveness. You evaluate her, ask her to perform hyperventilation, and you are able to elicit the typical absence seizures. For the sake of discretion, I'm not playing video because this will be uploaded on YouTube. So this patient has typical absence seizures. So how do you approach any child who comes to you with seizure? The first step before you start anti-epileptic medication is to identify what type of seizure exactly it is, whether it is a focal onset seizure, whether it's a generalized onset seizure. If you're not able to differentiate between exactly what is the type of seizure, there's no, don't worry, you can always, put the label as unknown onset. And you will always have time to evaluate the patient further, ask the parents to record a video. If a patient has a recurrence, you will be in a better position to classify the type of seizures in follow-up. Many times we are able to make epilepsy diagnosis and epilepsy syndrome diagnosis only when you evaluate the patient and see them regularly in follow-up. So once you have identified the type of seizure, then comes the different epilepsy classification. So if a seizure is of focal type, then you will have focal onset epilepsies. Patients, those who have generalized seizures, they will have generalized epilepsies. And sometimes they can also have combined generalized as well as focal epilepsies. Few patients will have certain unique clinical features and they will fulfill the criteria of certain epilepsy syndromes. So for the beginners, you must understand that seizure is different from epilepsy and epilepsy is different from epilepsy syndromes. So seizure basically is an event where there is a transient occurrence of signs and symptoms because of abnormal, excessive, synchronous electrical activity in the brain, whereas epilepsy is a disorder where the patient is predisposed to recurrent seizure episodes. So there's an enduring predisposition to have epileptic seizures, and epilepsy is not free of other side effects. It is associated with neurobiological, cognitive, psychological, and social consequences. So the difference is seizure is an event, whereas epilepsy is a disease which predisposes to recurrent unprovoked seizures. And what is an epilepsy syndrome? So epilepsy syndrome is a unique epileptic condition which has a complex combination of signs and symptoms. So each epilepsy syndrome is different. Different syndromes will have a typical age of onset. They will have a chronology of sequence of events. They may have circadian rhythm, a particular mode of inheritance, choice medications, and every syndrome will have a different long-term outcome and prognosis. So today, as we're discussing generalized epilepsy, remember in generalized onset seizures, there are two types. One is a motor with motor symptoms and those with a non-motor symptoms. So the motor generalized onset seizures are tonic-clonic, myoclonic, or atonic seizures, and absence seizures, they come under the category of non-motor generalized onset seizures. So when we know we are dealing with a generalized onset seizure and this patient has absence seizures. So what next? Apart from the common generalized childhood absence epilepsy, there are other generalized epilepsies which we see in children, like juvenile absence, juvenile myoclonic absence, periodontal myoclonia, epilepsy with GTCS. We'll discuss all these, the few common generalized epilepsies in children. So once you have identified the type of seizure, then you move on to choosing the right anti-epileptic drug for this patient. So whenever you are treating patients with generalized seizures, remember you have to opt for broad spectrum agents, because if you use narrow spectrum agents, you will fail to treat generalized seizures, and sometimes you can also worsen the seizures. For example, if you give tiagabine or vigabatrin, you may end up increasing the absence seizures. Certain seizure medications like carbamazepine, oxcarbazepine can exacerbate myoclonic seizures as well as absence seizures. And few medications are completely ineffective in managing idiopathic epileptic seizures. So you should remember which drugs to use and which drugs should not use. So if you are dealing with generalized epilepsy or a combined epilepsy, or if you do not know the onset of epilepsy, then it's always safer to begin with broad spectrum anti-seizure medications. So what are the broad spectrum anti-seizure medications? Drugs like clonazepam, lamotrigine, levetiracetam, topiramate, valproate, zonisamide. These are the common broad spectrum anti-epileptic agents. So it doesn't mean that because all these medications are broad spectrum agents, you can start any medication for any given patient. There is no single wonder drug that is ideal for all patients. So no one size fits all. You have to choose the drug based on the patient characteristics. You have to take into account other ethnic background of the patient also. For example, clonazepam is a broad spectrum anti-seizure medication. It is a good choice of drug for myoclonic jerks, but it is ineffective in managing generalized tonic-clonic seizures. Lamotrigine is effective in managing generalized tonic-clonic seizures as well as in absence seizures, but it may sometimes increase myoclonic jerks. So you have to be careful which drug needs to be started for which patient. So when you start any drug, always take into consideration the ethnic descent, age, sex, and other comorbidities of the patient. For example, if you want to start carbamazepine and you know the patient is of Asian descent, then it's always prudent to test the patient for HLA-B1502 allele because they are at a higher risk of developing Stevens-Johnson syndrome if you start them on carbamazepine. You should also ask about family history and past medical history, ask about previous co-medications, or if a patient has had previous drug reactions before. So always try to include the patient's family before you choose any medication, and always explain them the risk to benefit ratio also, because all anti-seizure medications, they are not free of side effects. They will have their own side effects when you start them on treatment. So discuss with the family what are the pros and cons, what is the risk benefit ratio, give them a choice and involve them in decision making. So if you see the anti-seizure medications, we have lots of new medications now. The second and third generation AEDs have come up. Lots of medications have come up now, but it doesn't mean that the newer generation drugs are more efficacious than the older generation drugs. In fact, the only benefit of the newer medications is that they have lesser side effects, they are better tolerated, and they don't usually need serum drug monitoring. But efficacy-wise, even now, the first generation drugs are better as compared to the newer medications in lots of clinical scenarios. So whenever you start a child on anti-epileptic drug, remember our aim is to achieve complete seizure control by using minimum medications. Always prefer monotherapy, uh, give the lowest possible dose, and try that the patient does not have any unacceptable side effects. So for the index patient, we know we are dealing with absence seizures. So what are the first line medications for absence seizures? Ethosuximide, lamotrigine, and valproate. These are the first line agents. You must also remember which drugs you have to avoid in patients with absence. Remember, you should not harm your patient. Even if you're not able to help them, at least don't harm them by starting wrong anti-seizure medications. So how will you choose between ethosuximide, valproate, and lamotrigine? If you look at efficacy alone, ethosuximide and valproate are equally effective, and they are better than lamotrigine when used as monotherapy. But if you look at the side effect profile, ethosuximide is better than valproate because valproate has got lots of side effects. So the optimal initial empirical monotherapy would be ethosuximide. But if a patient has more than one type of seizure, like if a patient has absence as well as generalized tonic-clonic seizures, then valproate should be preferred because ethosuximide is not effective in controlling generalized tonic-clonic seizures. So as for absence, all other type of seizures also have some first line medications, and there are some medications which needs to be avoided. It's available in all standard textbooks. You can refer those textbooks. So once you've started a patient on medication, you can have three outcomes. Either your patient is completely seizure free, so that's a win-win situation. Sometimes a patient may develop intolerable side effects, so you have to stop the medication, opt for the next best first line drug. Sometimes the patient will not develop side effects, but you will not be able to control the seizures with the chosen drug. So how will you proceed? So when a patient is not responding to treatment with first monotherapy, then what do? You will have to increase the dose and titrate gradually up to maximum tolerated optimal dose. Always check for non-compliance, see whether your diagnosis was correct, see whether you were giving the right medication for that patient. And even if a patient is not responding to 2 to 3 sequential medications, then sometimes you may have to opt for alternative options like modified diet or epilepsy surgery. So if a patient is not responding, you increase the dose, still patient has uncontrolled seizures, check for compliance, see whether your diagnosis is correct, take history again. You can substitute or add a second anti-epileptic drug. Even if the seizures are still not controlled, then you have to look for alternative therapy. If a patient develops idiosyncratic reaction, then you have to stop the medication and choose the next best medication for the patient. Whenever you start any drug, you remember what are the common and adverse side effects for each anti-seizure medication. So, for example, zonisamide can cause ataxia, drowsiness, and renal stones. Topiramate can cause concentrating difficulty, word finding difficulty, again, and metabolic acidosis. Lamotrigine, we know it's infamous for causing Stevens-Johnson syndrome. Valproate has a long list of side effects. So you must remember the common side effects and monitor the patient for these side effects whenever they come for follow-up. So for this patient, we have identified the seizure type. It was absence. We started the child on ethosuximide, but then she had some side effects, so we shifted on to valproate. We were monitoring for side effects, regular weight gain monitoring, advised her with few dietary modifications. So if you have started a child on medication and the patient is seizure free, what next? So usually what happens, most of us, we aim at seizure control, but seizure control is not the end point. Whenever we manage patients, we have to evaluate the patient and try to find out what is the underlying etiology and try to ascertain the epilepsy syndrome diagnosis. So once you have started the anti-epileptic drug, you have achieved seizure control. Simultaneously, you also have to appropriately investigate the patient, identify what is the epilepsy syndrome. So for absence seizures, what are the syndromes associated with absence seizures? You can have childhood absence, juvenile myoclonic, or eyelid myoclonia with absence seizures. So the gold standard in managing any patient with pediatric epilepsy is to try and ascribe a syndrome to every child with epilepsy. And if you properly work up the child, at least in 40% of patients, you will be able to identify a definite epilepsy syndrome in that patient. So we went ahead with EEG, and you can see with hyperventilation, this patient has typical 3 Hz spike wave pattern, which is the signature EEG sign of childhood absence epilepsy. So we know, as we mentioned, every epilepsy syndrome will have few inclusion criteria. So for childhood absence, if a patient is between 4 to 10 years old, previously developmentally normal and typical EEG features, you know that you are dealing with childhood absence. But if a patient has multiple seizure types like generalized tonic-clonic seizures or myoclonic seizures, or if there are some specific patterns in EEG like polyspikes, then you will consider alternative diagnosis. So you keep this child on follow-up, and after 1 year, you find that this patient is having myoclonic jerks. So now you have to change your diagnosis. So previously your diagnosis was childhood absence, but when you follow up the child, you find that patient is having new symptoms. So in pediatric epilepsy, the unique aspect is that the clinical presentation will evolve over time. You can have newer type of seizures, you can have new clinical features when you keep them in follow-up. So usually what happens, the trajectory of juvenile myoclonic absence is such that juvenile myoclonic epilepsy is such that they will initially have absence seizures, and within 1 to 2 years they will start having myoclonic jerks, and then it is followed by generalized tonic-clonic seizures. But there is lots of overlap between juvenile myoclonic epilepsy, childhood absence, and juvenile absence epilepsy based on clinical features as well as age of onset. But there are certain features which will help you to differentiate between these three. For example, in childhood absence epilepsy, usually the peak age of presentation is between 5 to 7 years of age, and in juvenile myoclonic epilepsy, they are seen in slightly older age group. Childhood absence usually will resolve by 12 years of age, but then juvenile myoclonic epilepsy, even though if you achieve good seizure control, you may need lifelong treatment in these patients. So the defining seizure in childhood absence and juvenile absence is typical absence seizures, whereas the predominant seizure in juvenile myoclonic epilepsy would be myoclonic jerks. And as the patient age advances, usually the absence seizures will become brief with age, though they may sometimes, some patients may have increased severity with age. And every syndrome has got a typical EEG finding, which will help you to differentiate between the three syndromes. So whenever you deal with a patient with juvenile myoclonic epilepsy, remember they can have more than one type of seizures. They will have prolonged absences, myoclonic jerks. They will also have generalized tonic-clonic seizures. And these myoclonic seizures, they also have a diurnal variation. So as for every type of seizure, we had certain choice medications for juvenile myoclonic epilepsy also. The first line medications are Levipil, valproate, lamotrigine, and topiramate. Remember, you have to avoid carbamazepine, phenytoin, tiagabine, and migabatrine in these patients. So when you have to choose medication, we know the first line drugs are valproate, Levipil, and lamotrigine. So the drug response is good with valproate. Up to 70 to 80% of patients will have good seizure control. But if you look at the safety profile, Levipil is safer as compared to valproate, because in patients with JME, they need lifelong treatment. So if you're treating a female, then you have high risk of teratogenicity when you continue this medication during adolescence and early adulthood. Along with medications, you must also remember you have to advise patients to avoid precipitating factors like sleep deprivation, ask them to avoid alcohol and other recreational drugs. So if you are using valproate, remember you have to use valproate at a lower dose because the risk of teratogenicity is higher if it is given beyond 1 gram per day. Nowadays, people are more and more people are using levetiracetam as a monotherapy in juvenile myoclonic epilepsy. There is an inclination towards using Levipil as a monotherapy in these patients. It has been found, though we don't have any larger studies in pediatric age group, it has been found that even Levipil, when used as a monotherapy, patients have good seizure control when used between the dose of 12 to 50 milligram per kg per day. Lamotrigine has also been found to be beneficial in juvenile myoclonic epilepsy, but in small percentage of patients, they can also worsen myoclonic seizures, though we don't have any long-term outcome or long-term follow-up of patients of JME who have been treated with lamotrigine. Brivaracetam is a newer promising drug. It has been used in many genetic generalized epilepsies, and even in juvenile myoclonic epilepsy, it has been found that the response rate is approximately 60% and 40% of them were completely seizure-free when brivaracetam were used in these patients. So we must also remember that we are not only treating seizures, we have to treat the patient as a whole. So we have to look for behavioral disorders, mood disorders, and anxiety, which is usually seen in 30 to 40% of patients with juvenile myoclonic epilepsy. So just imagine if this patient, you have started the patient on valproate, the myoclonic jerks are well controlled, you're taking care of all the behavioral aspects, and the patient is also avoiding all precipitating factors, but still she develops few complex movement disorders in follow-up. Now what will you consider? So you have to always keep looking back and try to see whether what is the underlying etiology and what best you can do for the patient. So if a patient comes with movement disorders and absence or features of juvenile myoclonic epilepsy, always think about GLUT1 deficiency syndrome. That is a glucose transporter type 1 deficiency syndrome. So this syndrome has got varied clinical features. It can present with early onset absence seizures. It can manifest with childhood absence evolving into juvenile myoclonic epilepsy. Some may also have significant family history with paroxysmal movement disorders. So you have to look at other aspects, like spasticity, ataxia, dystonia. So lots of movement disorders can also be associated with GLUT1 deficiency syndromes. Another clue towards GLUT1 deficiency syndrome is positive family history. So this is an autosomal dominantly inherited disorder. So you may get a positive family history where multiple members in the family are affected with different types of absence epilepsy and movement disorders. So again, if etiology changes, you have to optimize your management. If you're dealing with a patient with glucose 1 transporter deficiency syndrome, then you have to avoid valproate, phenobarbital, zonisamide, and topiramate. You will have to opt for modified diet and triheptanoid in these patients. So that's all about absence epilepsy and the common generalized epilepsy with absence. The next common type of generalized seizure is generalized epilepsy with predominant generalized tonic-clonic seizures. So in these patients, if you want to choose the drug, the first line medications are either Levipil or valproate. If you compare Levipil and valproate is superior to Levipil in terms of time to remission as well as good seizure control. Valproate is also better than topiramate and lamotrigine. People have found that in both in treatment failure as well as 12-month remission, valproate is superior to all the other first-line medications. So especially in subgroup of patients who had generalized epilepsy, valproate was proven to be superior than other common anti-seizure medications. But you must remember the common side effects of valproate. The patient may have either loss of appetite, sometimes they may develop severe abdominal pain, thrombocytopenia. Obesity is very common in girls. And in childbearing age group, you must always inform the family that there's a high risk of fetal malformations. And sometimes these children can also have postnatal cognitive impairment. So whenever you choose any drug for patients, remember that certain anti-seizure medications can worsen cognitive functions like topiramate, zonisamide, and perampanel. Few medications are known to decrease weight. So if a patient has a baseline obesity, then it's always better to opt between topiramate, zonisamide, and felbamate. There are also drugs, most of the drugs, they will cause increase in weight. So valproate, gabapentin, carbamazepine are known to increase weight in patients. And if you are using polytherapy, try to use medications with minimal drug interactions like Levipil, brivaracetam, lamotrigine. They have fewer drug-to-drug interaction. Next comes the future of management of epilepsy, that is pharmacogenomics. So usually what happens in clinical practice, if I have 5 patients with absence seizures, and if I give same medication to all the 5 patients, I will not get the same response in each patient. So every patient is different. Some patients will respond to a low dose medication. Some patients will require more than one medication. Some patients will not respond even if you give them multiple drugs. Why is it so? It is because of the genetic variation. So there are lots of genetic factors which influence pharmacokinetics, pharmacodynamics, the receptors and ion channels, and how the drug is metabolized. So because of all this variation, different patients, they behave differently. A simple example is the sodium channel disorders. For example, simple sodium channel disorder can have varied manifestations. On one hand, it can present with a Dravet syndrome. On the other hand, it can manifest as a familial hemiplegic migraine. So it's a huge spectrum of sodium channel disorders alone. Depending on whether it's a truncation mutation, whether it's a deletion duplication mutation, the manifestations will vary. So precision medicine is the future of I think all types of epilepsies now. So it's an approach for disease treatment and prevention based on the individual variability in genes and environment. So previously, we were taught to treat patients based on signs and symptoms. Now we are treating patients based on evidence-based medicine, and the future of pediatric epilepsy management would be based on the genetic diagnosis and precision medicine in future. I think that's all for today. Thank you for patient listening.
If anybody has questions to ask, please feel free. Either they can unmute and ask, or you can type in as well. Thank you, Dr. Razia, for a comprehensive talk. With children, when we are giving the medications, one of the things we are worried about is in drowsiness. I guess the same for adults as well. I mean, of these drugs, which are the ones that are least likely to cause drowsiness, or depends, or does it depend?
So first of all, the best thumb rule is to start at a low dose and go slow. So if you start at a lower dose and slowly titrate, most of them will not have drowsiness. But of course, benzodiazepines, they are more prone to cause drowsiness. Valproate doesn't cause drowsiness. Valproate, levetiracetam, they don't have usually drowsiness in patients. Vigabatrin can cause excessive sleepiness. So, but phenytoin, levetiracetam, valproate, topiramate, they have less tendency to cause drowsiness. But the best way is always to start at a low dose and then titrate them slowly. Slow titration is always safer. So I think there is a question in chat box which reads about when to stop, what is the criteria to stop, and when to stop anti-epileptic drug in case of seizure subsidence. Dr. Manohar has asked this question. So the decision to stop seizure medication has to be ideally individualized. It all depends upon what is the underlying etiology, how bad the seizures are, whether the child is having more than one type of seizures or not. But if a child is seizure-free on medications for 2 years, so if there is seizure freedom for 2 years, then you can taper and stop seizure medications. But you must also remember that patients, those who have multiple type of seizures, or those who have abnormal EEG after stopping the drug, or those who require multiple medications, or if there is a remote symptomatic epilepsy, these patients can still have a recurrence. So recurrence risk after stopping medication is to the tune of 30% in
Madam, good evening. I am Dr. Lakshman Kumar from Karimnagar. Good evening, madam. So excellent presentation, because it is a common problem we come across in our practice. My question is, we sometimes we do see the meningoencephalitis cases children. They will have 1 or 2 episodes of seizures. So do you think that we have to continue the AED for our generalized seizures or something, or any lesser duration? So because I got 2 to 3 children, they have been almost using for so many years, 3-4 years, but developmentally they are normal. But some of the neurologists, they are advising to continue for 5 years. So what is your opinion, madam?
So children with acute meningoencephalitis, they usually have acute symptomatic seizures. So in acute symptomatic seizures, usually they do not need long-term medications. You can always taper and stop medications over 2 to 3 months. But it also depends upon if a child had significant status epilepticus, if a patient has developed hypoxic damage, or during meningoencephalitis, patient has developed stroke. Then in those patients, sometimes the anti-epileptic can be continued for a longer duration, but in usual clinical scenario, you can taper and stop medications over 1 to 3 months once the patient is asymptomatic. once the acute phase is
So if somebody is on generalized seizures and maximum dose of valproate, then he is having breakthrough seizures. So what is the next add-on? I am using clobazam. So anything that one to be better, because we is on maximum dose of valproate. So what should be the next drug should be added in those cases?
So for a patient with generalized seizure, you can always, and you've already reached the maximum dose, you can add levetiracetam as a second medication.
What is the medication, madam?
Levetiracetam can be added, sir.
Levipil, sir. Levipil.
And Dr. Aparna has asked a question: what is the role of MRI and EEG in the first episode of unprovoked seizure? So every patient with first episode of unprovoked seizure should be evaluated, and EEG and MRI both are warranted in these patients, because your EEG and MRI will tell you about the risk of recurrence. So if a patient is having normal MRI and abnormal EEG, then the risk of recurrence in these patients is about 40 to 50%. If a patient is having seizure with abnormal MRI and abnormal EEG, then the risk of recurrence is to the tune of 60%. So it will help you in establishing the underlying etiology. It will also tell you what is the risk of recurrence, and you can decide about starting anti-epileptic agents in these patients. So ideally, every patient with first episode of unprovoked seizure should undergo MRI and EEG.
Dr. Kamran has got a question, madam. Any cognitive and behavioral changes in long-term therapies?
Yeah, so the older first generation anti-epileptic medications like bromide.
button
Request people to use.
Okay, so the first generation anti-seizure medications like bromides and phenobarbital were associated with long-term cognitive effects. Even levetiracetam, though it is rampantly used, it also has got behavioral side effects in few patients. And also few medications like topiramate. Topiramate can have cognitive impacts on patients. So you have to see the risk-benefit ratio. But some patients may also have cognitive effect because of the underlying etiology. And if a patient has difficult to control seizures, like Dravet syndrome is known to have behavioral issues and intellectual disability. West syndrome will have intellectual disability. So sometimes it's the epilepsy per se which is having a negative cognitive impact, but there are few medications which can have a negative impact on cognition when used long term.
I think there is another question on monotherapy having seizures. I think that's answered already.
Yeah.
Dr. Razia, is ethosuximide available and prescribed these days?
Yes, ethosuximide is available by the name of syrup Absence. The name itself is Absence, ABSENZ. And the concentration is 5 ml to 50 milligram. You can start with 20 milligram per kg per day. And maximum recommended dose is 60 mg per kg per day, but don't give more than 1.5 gram in children.
Okay.
That's a ceiling dose. 1.5 gram is a ceiling dose.
Okay.
It is easily available now.
It's easily available. Okay. So, for in a broad sense, for a general pediatrician, for generalized epilepsy, the drugs of choice are valproate and levipil.
Yes. Even topiramate can also be used, topiramate zonisamide, but levipil and valproate.
Topiramate or monotherapy, madam, or as an add-on?
Add-on. Topiramate, lamotrigine can also be used, but if you start with, either you opt for levipil or valproate.
Okay. There's a role of ketogenic diet. There was Dr. Kamran is asking role of ketogenic diet in epilepsy.
Yeah, so ketogenic diet has a role in lots of epilepsy syndromes, but usually ketogenic diet is used in patients those who do not respond to polytherapy. But there are few syndromes like Dowser syndrome and West syndrome where ketogenic diet has got very good results. Even sometimes patients who have refractory status epilepticus, we have to offer ketogenic diet in those situations.
But I guess that should be under neurologist and dietitian supervision and done carefully conditions, I guess. Okay.
Madam, one more, this one, Dr. Lakshman Kumar from Karimnagar again. So this seizure disorder, parents, a lot of parents ask the TV and gadgets use. So what I'll say that 6 months, I will say that they should do away. I am practicing for the last 30 years. So what I say is that 6 months should be avoidance. Any guidelines are there on that one, whether it's the gadgets, mobile, laptops, the iPhones, plus the iPads are there, TV and swimming. So much of is there any the guidelines is there from any for general public and practitioners, madam? The
Yes.
non-seizure disorders children who are on AED.
So patients will have parents will always be concerned whether patient can be sent for swimming or any outdoor activities. So you have to advise that patient can swim, but that patient should be accompanied by an adult or a coach who knows how to swim. So you don't leave the child alone. And if a patient wants to cycle, they can go for cycling, but they should always wear helmet. Don't allow the patient to play in terrace or in balcony alone. And if the terrace is not having those, if they don't have the safety guards, then don't allow children to play alone in terrace and balconies. That should also be advised to them. Regarding gadgets and screen time, ideally, children should not use screen more than 2 hours in a day. That's for children beyond 5 years of age. Children between 2 to 5 years of age, the screen time is 1 hour per day, and that too with frequent breaks in between. For patients who are suffering from epilepsy, especially if they have photosensitive epilepsy, then you have to avoid bright light. You also have to ask them to avoid going to cinema halls. And if they are watching TV, they should watch TV in a bright room. They should not watch TV in a dark room. And try to maintain a distance of 5 to 6 meters away from the screen so that they do not precipitate any photosensitive epilepsy or sometimes excessive screen time or sleep deprivation. These things can also trigger seizures in few patients.
Dr. Sindhuja is asking about prophylactic treatment in post-head injury patients, madam. I guess it comes as symptomatic seizures.
Yeah. So head injury patients may need medications for a brief duration. Usually you can stop medications after a couple of months, but if a patient has got significant scarring or because of head injury, they have sometimes they will have secondary massive intraparenchymal bleed. In those patients, you may have to use it for a longer duration, but otherwise you can stop it in a couple of weeks. And okay, prophylactic, was it a prophylactic AED? Yeah. So the prophylactic drug is phenytoin. In most of the books where it is mentioned is phenytoin, but people also use Levipil as a prophylactic anti-epileptic drug in patients who come with traumatic brain injury. You can observe the patient for a few days, and if patient is not having any features of raised ICP, is not showing any seizure, then you can always stop the drug at discharge.
Any other questions, Pooja, from WhatsApp or YouTube?
No, sir. No other question on WhatsApp. But I
think there is.
So
Lakshman Kumar said it's a wonderful presentation.
Thank you.
Good afternoon, madam. I'm Dr. Santosh. Yeah, I've got a small question, madam. What is the role of EEG while starting therapy and follow-up and discontinuation of AEDs, madam?
Okay, so first of all, you must remember EEG will not help you to make a diagnosis of seizure. So the diagnosis is clinical. So only with his clinical history, you will be able to ascertain whether the patient has a seizure or not. And you will see, I mean, you must have seen in your clinical practice that when you perform an EEG, most of the patients will have a normal EEG. So a patient has a clinical seizure, but if he has a normal EEG, does not mean that you should not start the patient on treatment. But if a patient is having abnormal EEG, then you can always, it will help you to decide what is the risk of recurrence. Plus, if you find any specific changes in the EEG background, like for example, if a patient has 3 Hz spike and wave pattern, then you know you are dealing with a childhood absence seizures. If a patient has hips arrhythmia, then you know you are dealing with infantile spasm. So EEG will help you in making an epilepsy syndrome diagnosis. It will also tell you how bad the background is. It can give you a clue towards the risk of recurrence. If there are any focal seizures, any focality, then you know it can be a localization related epilepsy. Sometimes children can worsen during the treatment and they develop non-convulsive status. In those situations, EEG is helpful. So there are specific indications for ordering an EEG, and but usually EEG will not help you to decide whether you have to start the child on medications or not. And while you're treating a patient, and if a patient is having good seizure control, then you need not repeat EEG in between. You can repeat EEG if a child is having new type of seizures, or if there is a change in behavior, or if you think if the child is having any continuous slow wave discharges in sleep, like CSWS or non-convulsive status, then you can order for EEG. If a previous EEG is abnormal, then before stopping anti-epileptic drugs, it's always better to repeat an EEG before stopping drugs. And so that's it. And sometimes in acute scenarios, like if a patient is in ICU, then EEG will be helpful in picking up electrical seizures.
So what you're
One more
saying,
question, madam.
Pediatrician is in the periphery and he has diagnosed a seizure type, he can safely start the drugs without worrying about the diagnosis or differential or syndromic diagnosis.
You can start the drug and you can always get EEG in follow-up.
Madam, one more question, madam.
I got a question.
Yes, please.
Dr.
Kamran, there's got a question. Can you see that, madam?
How long do we continue anti-epileptic medication, and what are the indications for cessation of anti-epileptic drugs? I mean to say, when do we stop? What are the parameters or investigations for stopping anti-epileptic drugs? How long should a child be seizure-free? And what other like EEG or any other phone is it?
I think madam has answered once, but you can briefly tell again.
Okay, so child should be seizure-free for 2 years before you taper and stop anti-seizure medications. The reason, so this duration has been debated a lot. Previously, some people said 1 year, 2 years. Some people also had vouched for 5 years. But the evidence says that if a patient has to have a recurrence, then 50% of them will have a recurrence in the first 6 months. 70% of them will have recurrence in 12 months, and 88% of them will have a recurrence within 2 years. So that is a safe margin. So if a patient is seizure-free for 2 years, then you can taper and stop anti-seizure medications. And a very small percent of patients can have recurrence even after 5 years of the first episode. But that's a very, minuscule percentage. So 2 years is taken as the general practice parameter. But you always have to tailor the management based on the individual. If a patient has difficult to control seizures, multiple type of seizures, has a remote symptomatic epilepsy, a child is neurologically or has neurological deficits, then you may have to continue medication for a longer duration. And there are certain aspects which will also help you to decide about the seizure recurrence, like if a patient has a seizure onset in adolescent age, or the seizures occur in sleep, or if a patient has abnormal EEG, then these patients, or if the patient has a positive family history, so these patients tend to have higher recurrence in follow-up. I think that answers your question, sir.
Madam, in case of adolescent onset idiopathic generalized epilepsy, is it 2 years to continue AEDs, or madam, is it 4 years as you have mentioned now only? So juvenile onset epilepsy.
Yeah, it depends upon the epilepsy syndrome diagnosis. So if it is a childhood absence seizures, then usually by 12 years they will have the seizures will. If a patient has juvenile myoclonic epilepsy, that's a primary generalized epilepsy in adolescent age, then you will have to give lifelong treatment in those patients. So it depends upon many things, depends upon your epilepsy syndrome diagnosis, depends upon the neurological status of the child, depends upon the MRI of the baby. So many things have to be taken into account.
Dr. Kamran,
and in case of outside, they have started any anti-epileptic medication, and now we want to take it out because it is not an ideal AED. So now we want to add an AED. So whether we need to taper it and add this AED, or we need to we can abruptly stop that AED.
Yeah, so that is a very valid question. So if a patient is already on a anti-seizure medication and the patient is not having adequate seizure control, so how to add the second drug? So always avoid abrupt cessation of any medication that can worsen the scenario. Sometimes they can have increase in breakthrough seizures. So one option is, so if, for example, a patient is on 30 milligram per or 40 milligram per kg of valproate and the child is not responding to that medication, so you can add a second drug, gradually titrate the second drug, reach the optimal therapeutic range, and then once you have achieved seizure freedom, then you can gradually withdraw the first drug which was not very effective. So that is a safer way. So don't stop the first drug immediately. But if a patient is on a wrong medication, for example, if a patient has myoclonic jerks and a patient is receiving carbamazepine, then there's no point in adding a second drug while you continue carbamazepine. Then you have to definitely stop carbamazepine and add the appropriate drug for the patient.
Madam, one more thing, madam. Practically, what we are facing bedside, in case of epilepsy partialis continua, as we don't have EEG at our center, so can we diagnose it clinically bedside, madam? Are there any means to diagnose it?
So epilepsy partialis continua will have continuous partial seizures, but if it is prolonged, then sometimes it will also affect the sensorium of the baby. So I don't think you can make a clinical diagnosis. If you have EEG, it's better. But if you don't have EEG, even then if a patient is continuously seizing, you can make a diagnosis of epilepsy partialis continua. But it also depends upon the etiology. Sometimes they will have HHE, so MRI will be needed, because if patient has HHE or Rasmussen encephalitis, then you will need to start them on immunomodulators.
Okay, madam, I got one question.
Yes, please.
In clinical practice, what are the most common types of inborn errors of metabolism which manifest seizures?
So
inborn errors of metabolism manifesting as seizures, very common.
Okay, so organic acidemias will manifest as seizures, pyridoxine-dependent epilepsies, non-ketotic hyperglycemias, they manifest as seizures commonly. But if a patient also has mitochondrial cytopathy, they can have various types of seizures. So organic acidemias, pyridoxine-dependent epilepsies, NKH, mitochondrial cytopathies. But the list is very long. These are the common ones.
Dr. Kamran is asking a question, madam. If there is no adherence to therapy or discontinuation of the treatment and the child is seizure-free, is it necessary to restart therapy again? And an ideal time to take an EEG after a seizure episode? Okay.
So the ideal time to take an EEG after seizure episode depends upon the clinical condition. If a patient is ill, he is in ICU, having altered sensorium, you are thinking of non-convulsive status, then try to take EEG as early as possible. If a patient is stable, walks into your OPD, then you can always take EEG anywhere between 3 to 7 days.
3 to 7 days. And the other question was, if the child is not compliant with treatment or discontinued and they're seizure free, do we need to do anything?
Okay, so here you have to counsel the family, tell them about the pros and cons of a breakthrough seizure or a prolonged seizure. And if they are non-compliant and not willing to treat the patient, then I don't think we'll be able to help them much. But it's always better to inform them, document it, that you have counseled the family about the risk of seizures, about you have given them the option. I think that needs to be decided based on case-to-case basis. Sometimes patients, if they are not convinced enough, then you can't do anything.
Okay. Dr. Lakshman is asking, for neurocysticercosis, what is the choice of drug and how long do we give it? AED.
I think, sir, we are
Yeah,
I would
going.
like that we stick to the topic. NCC is another whole. It's a different topic.
Yeah, I think they're probably asking about symptomatic seizures, like some patients. So again, they ask about meningitis and meningoencephalitis. I think you answered that earlier.
Yeah, ma'am. Dr. Sindhuja has asked that duration need to wait for EEG test after seizure attack.
I just answered this question. So again, depends upon the clinical scenario. If a patient is in ICU, if patient is ill, continuously seizing, has altered sensorium, you're thinking about non-convulsive status, or child is in encephalopathy, then try to get an EEG as early as possible. Another indication of EEG would be to see if you have achieved suppression burst pattern with hypentone infusion. If a patient is stable, he is not having multiple seizure episodes, then you can do EEG anywhere between day 3 to day 7 of the first episode of seizure. It also depends upon your availability. So, but if you do early, sometimes it is mentioned that early EEG can have focal slowing after a seizure, and if you and there's no point in delaying EEG a lot. So the most of the books recommend between day 3 and day 7.
Are there any more questions, Pooja?
No, sir. One question in chat box. I think you have seen this. Now, in case of infection like meningitis or
Yeah, that I've already answered. Meningoencephalitis.
yeah, so these were the questions only.
If there are no questions, shall we end the session, Pooja?
Yes, sir. So,
Okay.
Thank you, everyone.
so I thank you all the delegates who were here for joining this session by Dr. Razia. It was a very nice and interactive session, I will say. Thank you, ma'am. Thank you, Razia, ma'am, very much. And I thank Dr. Srinivas Jakka for moderating it, taking all the question and moderating it well. Thank you, everyone. Thank you for your time.